Welcome to our Everything Parkinson's webinar. Thank you for being here today on a wonderful Monday. It's sunny outside, so weather's really good. It's a great time to learn about Parkinson's today. Today we have two very special guests who is part of our team. We always talk about building our team, and that is more than your providers, your Dr. Petrosian, your movement disorder neurologist, your nurse practitioners. We definitely have other members of our team that are vital to optimizing your Parkinson's. And so we have two very special guests today, which are Annika and Katrine. So I wanted to just give you a little bit of background for both of them. So Annika is a speech language pathologist here at Pacific Neuroscience Institute. She specializes in treating patients with cognitive, motor, speech, language, and swallowing disorders due to strokes, due to traumatic brain injuries, brain tumors, and the neurodegenerative processes. This includes Parkinson's disease and Alzheimer's disease. She champions individual, evidence-based, and patient-centered care. She is also Speak Out certified. Annika holds a bachelor's and master's degree in communication sciences and disorders from MGH Institute of Health Professions. As a student, she was awarded several accolades. She also facilitated aphasia community groups in NYU, and she completed her clinicals at the Cedars-Sinai Medical Center, specializing in outpatient neurological rehabilitation. She loves to travel and she enjoys some good books too. Katrine is also a speech and language pathologist that specializes in swallowing, speech, language, and cognitive disorders, and gender affirming voice therapy. Katrine has experience in conducting fiber optic endoscopic evaluations of swallowing, like the modified barium swallow studies, cognitive speech and language evaluations, and developing person-centered, holistic, and evidence-based practice interventions for patients. She is also Speak certified and LSVT certified as well. Prior to joining PNI, Katrine was an SLP or a speech pathologist at the Veterans Affairs and Healthcare System in the Bay Area and New York Presbyterian Queens, where she worked with adult population in critical care setting and outpatient setting. She's also, this was very interesting for me to learn, Katrine, if she's a special education teacher, a softball coach, and NCAA softball national champion. That's awesome. Before attending her graduate school. So during her personal time, she enjoys surfing, paddleboarding, traveling, and she does have a golden retriever. I want to see and meet her too someday. So without further ado, please welcome our wonderful speakers for today, Annika and Katrine.
Thank you, Giselle.
Thank you so much, Giselle. Okay, I'm going to share my screen here. Okay. So, yes, thank you so much, Giselle and Dr. Petrosian, for having Katrine and I come to speak today. Like Giselle said, my name is Annika and my colleague here is Katrine. And we're just going to give an overview about what you might expect coming to see us for speech and swallowing concerns as it relates to Parkinson's disease. So to just give a kind of a brief overview about what we will talk about today, we'll talk about how we might evaluate and treat concerns relating to speech changes, swallowing changes, and also cognition. Our scope of practice covers a wide range of concerns that might bring you in. So we're going to talk a little bit about all of those. We're going to provide some examples of exercises that we often give to strengthen the muscles for speech and for swallowing. And then at the very end, share just a couple of patient experiences for folks who have done speech therapy with us. So I wanted to start with just some common, I'd say the most common patient concerns that we hear as it relates to the Parkinson's population. So we often hear things like, my spouse has a hard time hearing me, replace spouse with friend, caregiver, family member, right? My voice doesn't sound like it used to. I often have to repeat myself, or I cough when I eat or drink. Food feels like it's getting stuck in my throat, or I can't eat or drink as fast as I used to. So if any of these kind of resonate with what you're experiencing, the good news is that we can address all of these concerns, and with practice and with exercising, we often do see improvements across all of these. So we'll start off talking about just speech difficulties with Parkinson's. So the most common motor speech disorder that we see in the Parkinson's population is what we call hypokinetic dysarthria. And as you can see by this statistic, it occurs in 70 to 90% of patients with Parkinson's at some point. And so symptoms of hypokinetic dysarthria include reduced volume, shorter breath groups, monotone vocal quality or hoarseness in the voice, fast or excessive rate of speech, and articulatory imprecision, which translates to a mumbling kind of voice. So I wanted to show this graphic kind of to illustrate how much actually goes into what happens when we speak, right? I think oftentimes we think about speaking as just opening our mouths and the sound coming out, but there's a lot of things that are involved in what makes that happen, right? And so we don't really think about exercising these kind of muscle groups, right? We think about exercising things like your arms, your legs, your core for balance and strength. But just like any other muscle group in the body, we can exercise the muscles that are needed for speech and swallowing to strengthen the voice and make swallowing more safe. So when you come in for a speech evaluation, we will do an oral mechanism examination, which really just looks at how are the muscles in the face moving as far as strength and range of motion. We talk a lot about your experience, and we have you fill out questionnaires so that we can better understand how it's affecting your life. And I wanted to highlight that we use volume as an objective measure, not just in the evaluation, but throughout your course of speech therapy, because a lot of the times we also hear patients say things like, well, I feel like I'm speaking loud enough, or if I speak any louder, I feel like I'm shouting, right? And so Parkinson's also affects your perception and how you're perceiving yourself and how loud you are to other people. And oftentimes when you habituate to speaking at a lower volume, your threshold for what sounds like something that is too loud also is affected. So volume is a nice sort of equalizer. And like I said, it's an objective metric that we use to quantify your progress over time. So that's what happens at your first session. And then moving kind of into therapy itself, right? I say there are two main goals of therapy for both speech and swallowing. Number one, to build the muscles that we need to speak and to swallow, right? Going back to that diagram that I showed earlier of all of the different muscle groups that are involved. And then number two, bringing awareness to how you are speaking and swallowing. The exercises that we give you in therapy are sort of at that point lifelong, right? And so we want to establish early on that these exercises are meant to strengthen your voices and the swallowing mechanism. And they're sort of meant to follow you for the rest of your life, so that we can maintain the progress that we make for as long as possible and stave off any changes for as long as possible as well. So in speech therapy, right, we do exercises that target all of the different kind of groups that I had talked about earlier. So improved breath support, right, and coordination specifically for speech. How do we have your articulation sound more precise and more clear so that you enunciate better? How do we improve your vocal quality? And how do we improve also the vocal intensity or the volume of your voice? As Giselle mentioned when she introduced us, we use evidence-based, research-backed programs like Speak Out or the Lee Silverman voice treatment, which are designed specifically for folks with Parkinson's and have been shown to really show great improvements over time with intensive practice. And so I have this in italics, right? Establishing a home exercise program, which is really, really key to seeing progress and maintaining it for as long as possible. We kind of drive home the importance of doing regular practice every single day. And I work with my patients too to figure out what does that mean for you and what does that look like among your daily routine, right? How can we fit in speech therapy and speech exercises into that to make sure that you're really showing the progress and maintaining it for as long as possible. And then when respiratory drive is weak, we might also use what we call expiratory muscle strength training. And I know Katrina is going to touch on this too in a little bit, but we might use a device like this or exactly this that targets the muscles in your abdomen and in your core that are needed for exhalation and improves speech and swallowing. Okay, now I, feel like I can talk until I'm blue in the face about why I think speech therapy is important, but I think seeing it and actually seeing, from a patient who is experiencing it can be much more powerful. And so I have a patient here who's a real patient of mine who very graciously agreed to have one of his sessions filmed so that we can show in real time, right, what a speech therapy session might actually look like. And so he's not an actor, this is his real speech therapy session. And I just put together a little bit of his session to show, okay, this is what you might expect to see in speech therapy.
Okay. Me, my, mo, moo.
Me, my, mo, moo.
Wonderful, good. Keep those shoulders as relaxed as you can. Try that again.
Me,
Excellent. And I like the way you fixed that posture there where your chin was stuck a little bit and then you kind of made it more neutral.
Right.
But I'd rather you take a breath than kind of run out of air and then not have any voice towards the end. So let's try that one more time. Let's just make sure you're focusing on that breath support too.
The hare was making fun of the tortoise one day for being so slow. Do you ever get anywhere? He mocked. Yes, replied the tortoise, and I get there sooner than you think. Let's race, and I'll prove it. A clock and watch both tell the time, but a clock sits normally on top of a dresser or end table, and a watch you wear around your wrist.
Good. Okay, I like the pacing so far. Make sure you're really enunciating every sound as well, okay, so sound as clear as possible. And so take a nice deep breath before you start and then project that voice forward.
A sheet and a blanket keep you warm at night, but the blanket is much thicker and helps you keep warmer.
Okay, so just a little bit of a flavor of what speech therapy looks like, right? This patient had been doing sessions with me for a few, I think 4 or 5 at that point. So he was familiar with some of my cues. And so when I say, okay, nice deep breath, project that voice forward, he knew what to do in order to achieve that. I also wanted to address that, I have patients and, we have patients speak at a pretty loud volume in our sessions, somewhere between 80 to even 90 decibels, right? And so sometimes one of the questions or the concerns that I hear is, well, if I'm not expected to speak at 80 decibels, in my day-to-day life, what's the point of speaking and doing those exercises in therapy? And so I liken that to, let's say you were doing a bicep curl, right? You're lifting 10, 15, 20 pounds, not because you anticipate that you will need to lift 10, 15, 20 pounds in your day-to-day life, but because that's what you need to do to strengthen the muscles, right, in your arms. And so research has shown that the best way to strengthen the muscles for speech and to improve the speech is to speak, right? And so we can think about the intensity at which we do that, repeated practice over time, and the volume at which we do that as adding weights when you're doing weight training exercises, right? For any other part of the body. Okay. And then I very just quickly wanted to mention what we call alternative and augmentative communication, which for our patients who maybe have more severe speech concerns or who have trouble communicating just by verbal communication, just by speech, there are options for what we call speech generating devices. Think about a tablet or an iPad that you can type on or that you can press buttons on in order to supplement your verbal speech. I don't often say that this will, I mean, I almost never say that this will replace verbal speech, right? But I think it's something that for folks who are having a harder time with their verbal speech, there are other options to help you and make sure that you still have access to communication. This is definitely also not the first thing that we try with patients who come in with speech concerns related to Parkinson's. I'd say a majority of the time, the exercises that I had mentioned before, some of the exercises that we do really do make a difference over time and really improve our patients' outcomes. But I did want to mention this as an option for folks with more severe speech concerns. Okay, I'm going to pass it off now to my colleague Katrine to talk a little bit more now about swallowing and Parkinson's disease.
Yeah, so we'll talk a little bit about eating and drinking and the swallowing process. I know we don't really think about this on the day-to-day until it gets really affected. So it's important to also understand what the normal swallow looks like. And we have 4 different stages of swallowing. The first part is called the oral prep, where we chew our foods, move it around the mouth, make it ready for us to swallow so we don't choke on it. Second part is the movement of our tongue, pushing the food towards the back of our throat. Then once it hits that throat area, it goes down into our esophagus and then into the stomach. Parkinson's can affect all 4 of these stages or certain parts of the stage, depending on the progression of where you are at this time. Okay, so when there is a swallowing problem, it is called dysphagia. What you can see in Parkinson's is that it reduces the movement, it reduces sensation. Eating and drinking can be really tiring just due to the general weakness that can impact your swallowing. You see that there's a really large range between 11 to 100% of people with Parkinson's that have dysphagia, and it can also vary in severity depending if there's any other comorbidities or other health concerns that could also be affecting you. Some of the things to watch out for are coughing, possibly choking with foods or liquids, difficulty taking vitamins or medication. Sometimes you'll see some drooling or a feeling of a sensation of something in your throat. So this is just a long list of signs of swallowing problems. Some people may feel all of it. There may be certain parts that are worse than others. The biggest complaint I get, though, is coughing when eating and drinking, not being able to eat the foods that you want anymore. And we'll go into this a little bit later. As the dysphagia worsens, if it does, there's something called aspiration. You may have heard this in different doctor's appointments before, and that is the fancy term for things, food or drink or liquids that can go down the wrong pipe. Over time, if this continues to happen, it can create something called aspiration pneumonia, where I can get into that a little bit later, but it's good to know some of these signs so you're aware of it. That way you can come in and we can talk about what the next steps are and how we can help with this. Okay. Some swallowing disorders can lead to discomfort when you're eating and drinking, poor secretion management, meaning there's a lot of saliva in your throat, in your mouth. It's harder to swallow. There may be some drooling involved. Difficulty taking medications, especially large pills. This can lead to malnutrition, weight loss, and dehydration, choking, and aspiration pneumonia. All right, so when you come in to see me for a swallowing evaluation, I'll also be doing an oral motor exam, just taking a look at how your muscles are working in relation to speech and swallowing. I'll do something called a clinical swallow exam, where we will sit down, we will talk about your problems, what your goals are in terms of eating and drinking. Number one goal is to still enjoy a meal with friends and family at restaurants, at home, with different people without having that stigma of feeling like you're choking all the time. I'll give you something to eat and drink. We can take a look to see what's going on, what your problems are. From there, I usually always recommend an objective swallowing study. One of them is called a modified barium swallow study, and this is also called a video fluoroscopic swallowing study. This is where you would go into a radiation suite, and there'll be a moving camera that will take a look at your swallow. I'll go into that in more detail and show you an example of what that looks like. The other form of objective swallowing study is called a flexible endoscopic evaluation of swallowing. And if you have ever been to see one of our ENT doctors, I'm sure they have also scoped you. And in that same way, I will do the same thing, but I will also be providing something to eat and drink during that time, so I can get a real-time perspective of how you're eating and drinking. You'll also be getting a patient-reported outcome, and it's an assessment tool for us to better understand what your problems are, and also for you to see, well, what's going on in my everyday life, and you would rate the severity of your swallowing difficulties. Okay, so let's talk about the modified barium swallow study. You will go to a hospital to get this done with a radiologist and a different speech pathologist. What this does is that it helps us see inside of your mouth and throat, so we could get a better understanding of why you have a dysphagia. We have a lateral view of your swallowing phases, which is what we definitely need to see when you go into this test. You'll be drinking and eating different barium consistencies that range from thin liquids to a pudding to possibly a cracker and maybe even a barium tablet to mimic medication, so we can see the flow of the food from your mouth all the way down into your stomach. It is a moving X-ray, so we can see how the food and the drink flow from mouth to your stomach. We can also detect whether or not it goes down the wrong way into your trachea or the right way into the esophagus. And we can also see if there's any food residue that gets stuck in your throat. And depending on what we see there, then we can talk about the different exercises and postures to maybe help swallowing to be more efficient and safer. Right. So this is a video. The left side is a normal swallow. So you have the arrow where the food will enter the esophagus and not your trachea or your airway. The dark that you see is the barium bolus, and on the right is a dysphagia. So you'll see it trickle into the airway, and that is what's called aspiration. So if we do see the aspiration under fluoroscopy, then we will go into more detail about how your muscles are moving, what's not working, and some strengthening exercises to help reduce that aspiration risk or prevent it. Okay, so the next swallowing study is called a FEES. We can do this at our ENT clinics. I will do it for you. This lets us also see your airway and making sure the food and the drink are going down the right way. We can also see if there's certain strategies and positions, meaning is a chin tuck better? Do you need to turn your head to the right? Maybe a breath hold could work to help protecting your airway. What I like about doing the fees is that you can come in anytime to see me. It doesn't require any radiation exposure. You don't have to drink barium, which can lead to constipation sometimes. And you can also bring in your preferred food and drinks, especially the ones that are most difficult for you. So we can work through that process and figure out what's going on and how you can eat it and drink it better. So I'll just show you a quick clip of an example of what a fee study will look like. I would be giving you different types of food and liquid, and I usually diet green so it pops up in your throat. You'll come into our ENT clinic. We use a scope like that will go through your nose. So right now we're going through the nasal passage, and then we go up against the soft palate, then make a 90 degrees down into the throat. So this view that you're seeing right now is the back of your tongue, the back of your throat, your epiglottis, which is the cartilage that folds over your airway, and in the middle, you can kind of see a dark area, and that is your airway or your trachea. And then you have the V right there. Those are your vocal folds. So right now she's swallowing liquid, so we can see in real time what that swallowing looks like, which is great because you can also see in real time what you're doing with different kinds of food and liquids. And then we can also try out different ways to make it easier for you to eat and drink. Okay. All right. So after we do all of these evaluations, then what? Every individual that comes to see me, we make it unique to that individual and see where you are in that time and how we can best help you still enjoy the foods and the drinks that you want. This means that I may be giving you some exercises to do, possibly changing the texture of your diet. So maybe having softer foods in the interim until we strengthen those muscles, your swallowing muscles back up. Sometimes it's adjusting your posture so it's safer to eat and drink. And then the more severe cases, there's alternatives to instead of feeding by mouth or eating by mouth. Okay, so the exercise that I will provide you, they are skill-based strengthening exercise. You can think of it like physical therapy, but for your throat. And this works on timing and the function of how you're eating and drinking. Eating is it's so quick, so we don't really think about the swallowing function, but when there is a delay or something is just off, that can affect your entire ability to swallow safely. So the exercises will target your throat muscles, lip muscles, tongue muscles to all help push that food down, and so you can eat safer as well. All right, so changing your diet if you're having more difficulty chewing, that's where maybe the softer foods can come into play. Changing the texture, even with this is the last resort for me, is to change the liquid texture to something more thick. I'm sure people have heard of mildly thick or nectar thick liquids or honey thick liquids, and I utilize that as more of a crutch until your body gets a little bit stronger for you to enjoy those thin liquids again. And just to caution, with the thickened liquids, we do like to confirm that you are safe to drink those thickened liquids under either that fees we talked about or the modified barium swallow, just because if you aspirate or it goes down the wrong way, that can cause more damage to your body than aspirating thin liquids. Adjusting your posture, so possibly a head turn or a chin tuck can help protect your airway a little bit better. Sometimes you have to take that one sip at a time instead of chugging it, so your body can have that time to coordinate that swallow instead of having that coughing attack. Alternating between food and liquids may help push some of that food down while you're having a meal so it doesn't build up and cause more difficulty with swallowing. And again, these postures that I may recommend, we also do it under the scope or an MBS to make sure they actually do work and they aren't worsening your swallow or making it go down the airway. My light just turned off in my office, so I'm just gonna stand up real quick and thanks everyone. Okay, so we can go to the next slide. Okay, so this is the more severe cases of dysphagia where maybe a feeding tube might be placed as the primary or supplemental nutrition that is also needed to continue doing the things that you like to do in life. Okay, so let's get into the swallowing exercises. These are the ones that I like to talk about, even though there may not be a swallowing disorder present just yet. It's good to know these. You can start practicing some of these to also sustain your current swallow function. And this is something that we would definitely do from the beginning when you come see me. So we'll go into each one. So the effortful swallow, you swallow with a lot of effort. Our goal is to make sure that the food or drink doesn't get stuck in your throat and you are improving the amount of force and timing of your swallow. So you can see that it's almost like swallowing a big golf ball where you're exaggerating all of those muscles so they can squeeze tighter so it can push the food down. The next one is called the Masako maneuver. This increases the movement of your throat muscles. So you can actually do this while you're in the car, watching TV, pretty easily. So you can hold your tongue between your teeth while you swallow, and you can feel the pressure in the back of your throat, the back of your tongue. That is, again, helping exaggerate that movement of those throat muscles that help push the food down into the right way. And with this exercise, don't have any food or drink in your mouth. So the second exercise is called the Shakir exercise. If you have the ability and the range of motion to do this exercise, I would encourage doing it. If not, then we will figure out a modified method to make sure that it doesn't cause any pain. But the purpose of this exercise is that it helps open the muscles up to the entrance of your esophagus. The first part is holding your head up for a minute, and the second part is performing 30 head raises. And you would repeat this 2 to 3 times depending on what your endurance looks like. Right. This next exercise is a Mendelssohn exercise. This one's pretty tricky, so it may take some time to do this. And the goal of this exercise is to keep the opening of your esophagus open longer. And to do this, you have to keep your larynx or your throat or your voice box in a raised position. So I have people feel we all have that Adam's apple notch in the front of our throat. So you can practice taking a regular swallow and feeling that movement of it going up. When it goes up, you want to keep it up there for about 3 seconds, but you are holding it up with your throat muscles. So your finger is only there so you can get that biofeedback of it moving up. And this should help you eat a little bit better. You can do this with food and liquid, but starting it out, I would recommend practicing with your own saliva to get this movement down. Okay. The next exercise that we do together targets your tongue and your lip muscles and movement. At PNI, we utilize something called the Iowa Oral Performance Instrument. It's an IOPI. It has resistance in kilopascal, so I will measure how strong your tongue is. And then I will create an exercise plan for you that helps increase that strength every single time. You get the feedback, which is great. The first video you see, it targets the front part of your tongue. So you get this tongue bulb, and I have you push up that bulb against the roof of your mouth. And we'll talk about when you come in, how many to do and what the frequency is. And then we also target the back part of your tongue. And so you can see here, so you're pushing it up against the roof of your mouth. And you can see in these diagrams how big your tongue muscle is, and it's really significant in helping move that food down the right way. So strengthening that definitely helps with your swallowing. Okay, we could go to the next slide. All right, and we touched upon the EMST device. It's good for voice and swallowing. For swallowing, it helps improve your cough strength. So any liquid that might be going down the wrong way, you have a strong enough cough to expel anything out. And we want to keep your airway clear. It helps target the abdomen muscles, chest muscles, even the throat muscles here to help you voice and swallow. I have the website on here if you are interested in how it does help people with Parkinson's disease, and if you would like to purchase it in the future.
Okay, so I'm also now just going to briefly touch upon cognitive difficulties that we might see and address in therapy as it relates to Parkinson's disease. So symptoms relating to cognition might include difficulties with planning, memory, attention, word retrieval, and also visuospatial processing. And so we, along with our occupational therapist counterparts, we work together to address these concerns. And again, I know it doesn't seem like it because we're speech language pathologists, but we do cover cognitive difficulties if that is something that you're experiencing. So in an evaluation, right, we talk extensively about what areas you might be having the most difficulty with, whether it's memory, whether it's word retrieval, whether it's task initiation or task completion. We have you complete formal testing to gather baseline data. And so we have standardized tests that look across all of the different domains of cognition, including memory, attention, language, visual spatial processing, problem solving, all of those things. And the nice thing is that we can also track that data over time should we need to do further testing in the future. And if it's appropriate or needed, we might recommend that you see a neuropsychologist to do even further testing and more extensive testing. Neuropsychologists are able to diagnose other either comorbid or other underlying cognitive difficulties that you might be experiencing. And so if that's appropriate, we work with your care team should we need or should we feel like that would be a great next step for you for further testing. But in cognitive therapy, what we do, I'd say the bulk is strategy training, right? So I have all of these strategies that I provide education on, right? Regarding memory, attention, planning, organization, whether that's visual organization or language organization. We work on strategies for word retrieval. And so it's a lot of education to begin with. And then we practice them through structured activities that I have in office that I can kind of show you, okay, this is a strategy for memory. How might this be applicable in this particular situation? And then I think most importantly, what we do is we put these strategies into action, right? How does what we learn in speech therapy and in my office, how does that translate to your daily life? And I think that is the most important part, and that is where we spend the bulk of our time. is what functional small changes can we make either to your daily routines or, you know, just to your day-to-day processing so that you are able to retrieve words, you know, during conversation, or are able to plan and complete a task without, you know, frustration or feeling like you're able to, right? Or how do we minimize misplacing personal items and forgetfulness, right? So we can address all of these things in therapy. And this is really tailored to your experience and the difficulties that you're experiencing on your day-to-day life. So I wanted to just end with a couple of quotes. I asked some of my patients who were either sort of halfway through or towards the end of their speech therapy programs to get their experience and see, you know, number one, what they learned, and number two, if they would recommend speech therapy to other people who are experiencing similar concerns. So this patient said, speech therapy has been helpful because it's strengthening the muscles in my throat. People can understand me better without me having to repeat myself. And so that's what this patient got out of doing these exercises on a regular basis. And then this patient said, speech therapy has helped me concentrate on speaking forcefully while focusing on enunciation. The exercises have given me back a stronger voice, which Parkinson's was trying to take away. Speech therapy has provided me with the confidence to socialize and be understood by friends and family. And I think this kind of really nicely encapsulates what our goals are for helping you with your symptoms, whether it's enunciating and communicating with confidence, whether it's eating the foods that you want to eat, whether it's, you know, going through your day-to-day life as efficiently, as safely, as independently as possible. All of these things we target and we work on together when you come in for speech therapy. This is just a list of some of the resources that we cited in our presentation. And if you have any further questions, please feel free to reach out to myself or to Katrine. You can also, of course, talk to your neurologist, Dr. Petrosian or Giselle, or whoever your doctor, your care teams are, about getting started in speech therapy. But of course, please feel free to reach out to us as well with any questions that you might have.
Thank you very much, Annika and Katrine. That was such an informative presentation today. So I think that's going to be really helpful for a lot of our patients. Just a reminder for our patients in this call, if you have any questions, there is a chat where you, or the Q&A, you can use the Q&A too if you have any questions. I don't have any questions right now, but I wanted to comment on a few things. I'm so grateful that you did include cognition, because I think a lot of times there is a misperception, I guess, of when you talk of speech therapy, that it really just entails the speaking voice versus cognition. And cognition is such a great part of speech therapy, and with our patient population with the Parkinson's, both the speech, swallowing also, and definitely cognition. So thank you for touching in on that as well. So I wanted to just ask with regards to swallowing. So either Katrine or Annika, please feel free. You know, one of the things that we tell patients regarding swallowing is the chin tuck too. Is that a good recommendation? Is that something that you would recommend?
That's a great question. We actually want to see it under an objective swallow study to confirm that the chin tuck is safe and efficient for the patient. Sometimes it's actually worse, depending on the severity of the dysphagia, and I've seen it under an X-ray study or a scoping study where it pushes it into the airway instead, and we don't want that to happen. So any postures or any thick and liquid diet recommendations, we like to confirm it under video to just be 100% sure that it's good for them.
That's a
That's
great, thank you so much for that information, because I think sorry, let me start my video here. Hello, everybody. I'm at a conference right now. I think that that's a fantastic point because we certainly don't want to make blanket recommendations. And I actually don't think I was aware of that, so I appreciate that. Is it fair to say, though, as a general rule, that it is generally fair to recommend to be sitting up straight,
Yes.
not eating in bed, and also to take smaller bites, smaller sips, slow down and alternate between bites and sips? Is that fair without having a swallow evaluation? Are those recommendations fair?
Yep, absolutely.
Okay. I wanted to comment a little bit sort of contrarianism here, just to get us a little bit controversy here.
Oh,
I read an article about thickened liquids where, though it seems like from that study that though thickened liquids, apologies if you guys are hearing the plane flying overhead here, though the thickened liquids might reduce the uh, improve swallow, it actually didn't improve outcomes, which is, I think, the big point is reducing the risk of pneumonia and reducing, mortality and things like that. And I think the concern was that even though in most cases it's easier to swallow a thicker liquid is also more dangerous when it is aspirated. So can you comment on that? Because, especially for patients who are in a more advanced stage or who also have cognitive issues that make it difficult for them to follow the recommendations of the swallow therapy, like, I'm a little bit torn about whether thickened liquids are a good idea or not.
yes, of course. So thickened liquids is the last resort, I would say, in my recommendations. We also would like to see you swallow that thickened liquid under fluoroscopy or under the scope to be 100% sure it's not getting aspirated. In regards to that study you were talking about, there are multiple studies that show that thickened liquids also is not aligned with the best quality of life due to it just doesn't taste good, to be honest. And two, it's
Right. Yeah.
thicker consistency, so it's not as natural as water. Yes, it can be safer, but also if it's not even moving through your throat, with that efficient drive that we would see under fluoro, then maybe thin liquids by teaspoon might be the better alternative to thicken liquids. But also we take into consideration what the patient is comfortable with, and there are
Yeah.
certain patients that prefer the thickened liquids because
Interesting.
for them.
Interesting. Yeah, I think that brings up, there are some cases where people will get dehydrated because they're refusing to drink the thickened liquids, and they do better with the liquids. But thank you for that comment. I was wondering about, and now seeing my memory, I've lost what I was going to ask. It will come to me in a second. But I'll sort of comment on a sort of another point. Again, I was really appreciative of both of your guys' talk today. For people who are on the call today or for our future listeners, we have a lot of people who really don't prioritize their speech. And we know that for people who come in with Parkinson's, motor gait symptoms, shuffling, etc., when they strengthen those, leg, core muscles, etc., they do better with their motor, the bradykinesia, rigidity, etc. And my question for you is, can you be clear on the evidence for early intervention in speech therapy for people who are not complaining about their voice? Like, I can detect it, but they don't detect it, and maybe even their spouse doesn't think it's bad. How do you, is there data on early intervention, like sort of at the very, very beginning stages of some speech difficulties that we can convince our patients to come see you?
Yeah, that's a really great question. I don't know, Christine, if you have specific resources or research that shows that, but I mean, even anecdotally, we see patients across a range of their progression, right? At the very beginning, right at the time of diagnosis, towards the middle and even towards the later stages. And I think across the board, and especially for folks at the beginning, when you can sort of get ahead of the changes that you might anticipate, knowing that 90% of our patients might present with speech difficulties at some point, you can strengthen the exercise, strengthen the muscles before they even get weaker, rather than having to backtrack and, okay, now the muscles are weak. How do we strengthen to get it back to baseline and then improve? So I think because in the same way that any physical therapy exercises to address balance and gait are sort of lifelong, it's the same thing with speech exercises. Once you start them, they're sort of with you forever. And I think the earlier you can get in, you know, the better. And as far as you don't really want to wait until it's hard to hear you before you strengthen the voice, right? We might as well start early, get you on a good program so that when we, you know, might expect the voice to change, you know what to do. You know how to cope with the speech changes. You know how to modulate the voice for a louder environment, for a group of people. It's already sort of baked into your routine. It's baked into what you know about, you know, speech and your voice, rather than having to backtrack later on. I don't know if you have anything to add to that, Katrine, but.
No, I agree with all of that. When we do meet and sit down with you, we kind of give you everything to know. I want to touch upon our Speak Out program that we do. Annika and I are both certified in it, and it's a really great resource for you and your spouse and family that is lifelong. So we will provide you, we work with the Parkinson's Voice Project, who is the third-party nonprofit foundation that supports that. So we would connect you with either getting a hard workbook or a e-source library, so you have all of these materials that we also do. And there are webinars on there that show how you can carry this over into your everyday life, even after we are finished with it. I provide this with all, before we even get started, to see if that's something you also want to be a part of, even early on, even if you don't have any voice difficulties at that time. Just having that community and the resources and that awareness can help you make that informed decision for yourself. And really, the earlier the better. And that way, if things get a little shaky down the road, you know what strategies to put in place, and you can come to us then for maybe a tune-up at that time instead of something that's devastating. So we're here for you.
Those are all really great points. I think the analogy I would give was it's always easier to maintain muscle than the rebuild muscle, especially as we get older. And by older, I mean over the age of 40, apparently, where it gets harder to put muscle back on, and easier to maintain it. So I think that's a fantastic point. I think the Parkinson Voice Project also brings up another element that, you know, let's be realistic. Like we all agree that speech therapy is fantastic. We want all of our patients to do it. But, you know, it's overwhelming to a lot of our patients, you know, all the things they have to do to maintain their functioning in the context of Parkinson's. Some of our patients are still working, you know, some of our patients are still dealing with their parents or whatever it is. So it's like, there's a lot on people's plate. So some of our patients have asked us, well, can I do it virtually? You know, I don't live nearby. Can I work with Annika or Katrine virtually? And I wanted to hear what your thoughts are on that, especially in the context of the Parkinson Voice Project, which is based in Texas and does a lot of virtual work.
Absolutely. I think of all of the speech therapy, you know, protocols that we do, I think Speak Out actually very nicely translates to the virtual setting. We typically will do maybe definitely the evaluation and maybe the first couple in person just to kind of get you started. But once, you know, patients are on a good exercise routine, it's very, very easy to do virtually, and they're not, it doesn't take too long, right? We kind of say like 20 minutes every day dedicated to speech. And I really like to also work with my patients as far as, let's find the time of day that works best for you. Like in the morning, right after breakfast, is that a good time to dedicate 15-20 minutes to speech exercises? If you're in the car sitting in traffic, nobody can hear you, so you might as well do some speech exercises. So I really work with my patients to figure out, like, we can find pockets in your day that you can dedicate to doing 5, 10, 15 minutes of speech therapy, including virtual virtual sessions.
Great. One thing you guys didn't mention, but Parkinson's Voice Project, when you go on their website, mentions it quite prominently, is singing. Can you speak to us about, the role of singing, how singing differs from speech, for people who are concerned about their singing voices, what your recommendations are? And I know you've worked with a lot of my patients about that.
That's a great point. I think, so Katrina and I, neither of us are singers, but we do have colleagues who work with us at PNI who are trained singers and who have backgrounds in singing. So that is always an option to see one of our colleagues. But from my understanding and from what I've seen even in therapy, singing really allows you to, it sort of forces you to coordinate your breathing for speech, which is really, really key when it comes to addressing the concerns related to Parkinson's. And so, yes, the Parkinson's Voice Project really champions singing, and they have like weekly singing groups online, which is great. And I know that singing, also music, taps into a different part of the brain that really gets people, it's almost like a different way to target the speech by way of music, which I think is really great. And so when patients have that background, I very much encourage it. I've seen patients have a hard time doing speech exercises, but then when you translate it into singing, it's like everything locks into place and you're able to take a nice deep breath and see, oh yeah, I can take a deep breath if I want to sing happy birthday, right? Or whatever it is. So yeah, I highly encourage it for sure.
Great, wonderful. Yeah, I think you guys highlighted such great points about what you do and the role you guys have and kind of the concept of the lifelong exercises. I just wanted to leave, because we're, I think, wrapping up now. And I'm sorry, Giselle, were there any questions from the group?
No, we actually
Not
don't have
yet.
any questions.
Okay, all
I'm
right,
glad we
well,
were able to talk about those things too and
yeah.
clarify too.
Yeah. So I just want to emphasize two things. One is that, it's, I think, a little counterintuitive when we talk about a strong cough, but I think it's very important to have a strong cough because inevitably we all have little micro aspirations, things going down the wrong way. And the difference in our outcome is the ability to cough things out. So that EMS T150 and other expiratory muscle strength techniques, that's the idea, is actually trying to have a strong cough. So I wanted to kind of really highlight that paradox, and the fact that everything that we do in this realm, speech, swallowing, and coughing, it's all an expiratory muscle, and that is a medical way of saying exhaling. And people have heard of these inspiratory muscle strength trainers when they've been in the hospital and they've had to breathe in deeply. Those are called incentive spirometers, really about inspiration. But we also need to really emphasize expiratory muscles, which include diaphragm and other muscles. And then the final thing I wanted to leave with in the last minute here is something that my patients I've seen commented on in conferences and things like that, which is we can sort of sum up what we're asking of our patients in three sort of steps. One is let's see, now my memory is failing me. Attention, intention, and no tension. So actually, I'll start with attention. Attention is what you get when you're working with the speech therapist. You're actually understanding, you're paying attention to what you need to do to have a strong voice, to have a safe swallow. That's the attention aspect, because we take things for granted. And then intention is doing things, with intent, with conscious deliberation. And then no tension is related to the fact that, a lot of our patients will notice their speech is fine most of the time, but when they go to have a kind of a difficult conversation, they stutter more, or they're up in front of a crowd and their voice is getting quieter. And so the role of stress that is part of the symptomatology of speech issues, cognitive issues, and I would say to a lesser extent the swallowing. But that's the kind of the mantra that I've heard a lot of my patients use is attention, intention, no tension. And I just want to leave you guys with that little nugget from my patients. And I'll stop talking because it's 1 o'clock now. Thank you, everybody, for your participation.
Thank you very much, Katrine and Annika,
So much.
for such rich presentation today. I think that's going to be really helpful for a lot of our patients who watched us live today and those that are going to be watching this in the future in our YouTube channel or at the PNI website. So thank you so much for being our expert panelist today too. We'll see you in a few months. Take care, everyone. Have a wonderful week. Take care.
Thank
Bye-bye.
you.
Bye.